All right, let's start episode 3. Thank you, everybody, for joining us today. My name is Joe Sweet from Cleveland Clinic, and we are privileged to have a global audience joining us today from many different countries to hear from our featured guests. We have Dr. Hael Abdely from King Faisal Specialist Hospital and Research Center, as well as Dr. Nadeem Rahman joining us from our own Cleveland Clinic, Abu Dhabi. This session will be moderated by Dr. Nizar Zein, our Chairman of Global Patient Services. And we hope at the conclusion of this seminar that you will complete our survey that will be sent out. We want to hear from you, our audience, as far as topics of interest and what we could do to continue to improve this webinar series. So without further ado, Dr. Zein, I'm going to hand it over to you to moderate today's session.
Thank you, Joe. Thank you all attending this webinar. And Eid Mubarak, happy Eid for the ones of you who celebrate the Eid holiday today. I believe is the last day of the Eid holiday. COVID-19 has certainly proved to be the biggest challenge that public health system globally had to face. While there has been uniformity in response across the globe with similar actions such as social distancing and management in the ICU, there have also been unique regional differences. And that is no different for the GCC region. The GCC region, and in particularly in Saudi and UAE, have taken a global leadership role through the COVID epidemic. This has been recognized in a number of ways, including publications describing their leadership role beyond their borders, as they provided assistance to major economies in the world, including China and Italy and other places. Yet there has been unique challenges in these regions, and for that we are honored to have two distinguished speakers. The first from Cleveland Clinic Abu Dhabi, Dr. Nadeem Rahman, who is the chairman of critical care medicine, who has been caring for COVID-19 patients, and we are highly interested in hearing his take on this epidemic. Our second distinguished speaker, Dr. Hael Abdely, who is the Chief Medical Officer of King Faisal Medical Center in Riyadh, Saudi Arabia, where it has been also the main facility caring for COVID-19 patients in the Kingdom of Saudi Arabia. Dr. Abdely is also an infectious disease specialist, so this is close to his heart and his place of expertise. So welcome, Nadeem, welcome, Hael, and we look forward to your presentations. We will go ahead with slide presentations, and I may periodically interrupt with questions. We'll leave some time at the end for everyone on this conference to ask their own questions. Nadeem, welcome back. Go ahead.
Thank you. Thank you for having us, Dr. Zein, Dr. Hill, CCF Global Webinar, everybody back home in Cleveland. Before I start, I just wanted to say a special thanks to our CEO, Dr. Rakesh Suri here at Cleveland Clinic Abu Dhabi, our Chief of Staff, Dr. Guzman, and our health partners at Mubadala for giving us a platform to share our global pandemic experience and to share that out there with the rest of the world. So thank you very much. Can we start with the slides then? So we put a little overview together. So it's been almost, what, 3.5, 4 months that we've been dealing with this. And we started actually a weekly webinar series that initially started with for our deployment intensivists. And that it got some good bandwidth, then we opened it up to the rest of the CCAD enterprise, and we also shared stuff back home with the Cleveland Clinic main campus. And I got a little bit of slack for doing this, not slack, but you know, what is it? So BAT-RAD G13 is actually the nucleotide sequence, 96% in similarities to the bat coronavirus. So I sort of call this Operation BAT-RAT G13. In essence, you sort of need a military mindset to sort of deal with this crisis management. So hence the reference. If we could have the next slide, please. So I just wanted to give a little bit of an overview of where we are, starting at baseline. It will help you appreciate where we are currently. And again, this is not about me. This is about, we have a wonderful team of nurses, respiratory therapists, physicians, and special shout out to my section heads, Jimmy Dibu, who heads our neuro ICU, Fadi Hamid, who runs our medical surgical ICU, and also one of the key members in the task force that I'll allude to a little bit later. And Vivek Kakar, he's our head of our cardiac ICU and is also our lead for ECMO. So without these three, we're nothing. And again, we put all the pieces of the puzzle together, so it's great. We have about 21 physicians, 11 associate staff members as well, a couple nurse practitioners, and our administrators, Borzo and Rajit, who's been instrumental. And it also gives you a flavor in terms of where our physicians are from in terms of training, from the US, from Asia, and from Europe. Next slide, please. So just to give you some reference, so these are our numbered admissions over the past few years. So you can see we've been sort of rising to the challenge. And if you look at 2020 right now, we're almost at 900 over 4 months. So if you extrapolate that out, we could be going towards over 3,600 to 4,000 admissions. So, nearly doubling of what we were baseline. And obviously this has to do with what we're doing with the COVID pandemic and also increasing our non-COVID acute care patient population. Next slide, please. So just sort of an overview, right? So this pandemic we got wind of it probably late December. It wasn't a pandemic at that point. It was called a public health emergency, I think on January 30th. So these infection rate has been increasing worldwide. 5% of our patients require ICU level of care. We're honored, we're humbled to be considered a center of excellence for COVID-19, meaning we take care of the sick of the sickest. So it's a great responsibility, and we are very proud of that. Next slide, please. It goes back to mindset, right? So some of us are intensivists. The beauty is in our critical care institute, we've blended together ICU physicians from cardiac surgeons to anesthesiologists to internists to pulmonary critical care to neurologists. But no matter what your background is in this sort of crisis management, you sort of have to go into a mode of a military mindset. And I think that's why, and we'll get to those points later, of why I think, the training that I've had back in Cleveland for over 20 years helps me. And again, as I said, it's not about me. If you took anybody from our class who spent 20 years at Cleveland, it helps you to be comfortable in these sort of situations. People who know me pretty well, I'm probably one of the few people who's sort of been excited during this pandemic. Not that you want to see these things, but you feel blessed that you have the opportunity and the skill set to help. So in terms of DEFCON, DEFCON 1, 2, 3, 4, 5, in terms of the Joint Chief of Staff, in terms of alert levels. So we're pretty much at DEFCON 1. Next slide, please. You can just keep on hitting it, please. So this is just an overview of where we are. So we're 72 beds at baseline that I alluded to in the original slide. So we've increased our ICU capacity 70%. That's not an easy task at all. So we've gone up to about 130 beds for these patients, and that gives a lot of credit to our executive administration who had the insight and the wherewithal to make these predictions ahead of time. And then I also want to, I want to give special thanks to our PACU, 24-bed PACU with nurses who weren't always used to doing this sort of post-operative ICU care. It's been amazing. Nobody skipped a beat. It's been fun. It's been fantastic. I get a little emotional about it because it was a seamless process. Everybody worked together. So as I said, 72 beds to 130, 70% increase in capacity. Truly amazing team to be a part of. Next slide, please. So other things that we've sort of done to help, right? Because obviously there's a lot of fear. Nobody likes change or whatnot, but we put different principles into play. Again, the whole team, the whole institute, right? So we started doing online WebEx courses for non-intensivists. So as I alluded to, we're about 35, 40 caregivers in our institute. we're up to 140 now. We've had wonderful support from our Heart and Vascular Institute, our Digestive Disease Institute, which is run by Dr. Crow, who's another colleague from main campus, and our Anesthesia Institute colleagues, Dr. Massimo, who's pretty much given us a full complement of FTEs to make this happen. Without them, we wouldn't be where we are. We created, the team was fantastic, you know, led by Dr. Deeboof, Dr. Fadi, and Dr. Jimmy, creating order sets, you know, to make things as organized and as seamless as possible. So we created templates for all the different workflows, such as dealing with, you know, ARDS, sedation, and anticoagulation. Next slide, please.
Dr. Rahman, just to clarify, so you went from what I don't remember the number of ICU critical care.
72.
72 to 140.
130.
30. So that move up, you trained non-critical care physicians to function as critical care physicians, or you recruited staff, or how did you do this to go up?
Absolutely. So the word we sort of came up with was a DI, meaning a deployment intensivist. So this is made up of anesthesiologists who are not critical care, DDI surgeons, GI physicians, Heart and Vascular Institute, CT surgeons, cardiologists, hospital medicine, and, you know, emergency medicine as well. So we put them almost sort of like a quick boot camp. And the way the model was done is you always have one of our intensivists in terms of to be there who will round with them. So no one was ever going to feel like left out, or we didn't put them out on an island by themselves. But truly, without them, we wouldn't be where we are today.
Great. Thank you.
You're welcome. And then in terms of treatment, right, as I said, ventilator management, because obviously all these patients have severe acute respiratory insufficiency, which turns into ARDS. You know, we went over algorithms for proning, renal replacement therapy, ECMO. So a lot of proper workflows, algorithms to make sure we have standardization, which obviously when you're dealing with such a high acuity patient population and you have to scale it up, it's the best way to go. And we've had wonderful support. I would be lost if I didn't say our ID colleagues. Without them, we wouldn't be here as well. So antiviral therapy, monoclonal antibody receptor inhibitors, and with our pathology colleagues as well in terms of using convalescent plasma has been shown to have beneficial effects. Next slide, please. And lastly, you know, I want to highlight something. This was one of the first times that we've ever done this. So, you know, we were called from a local hospital here. You know, there was a young patient, I get a little choked up, a young patient who needed our services, and they couldn't put him on ECMO at the outside place. So critical care transport is also under our institute. So a team assembled that was led by Dr. Vivek, who is our head of cardiac ICU, Dr. Bajwa, who runs our mechanically circulatory devices, one of our cardiac surgeons, a heart transplant surgeon, along with our critical care transport team, perfusionists, nursing, CCT nursing. So you can see that's a lot of people to put together. We successfully went to the outside hospital, cannulated this patient, and brought them back with no interruptions, which is, it's truly amazing. So, you know, this is the sort of the work that we're getting an opportunity to do. For those of us who know us back in Cleveland, you know, we've been doing this. You know, we've been doing this. You know, Dr. Barsoom in Cleveland Clinic, Florida. You know, they're doing a wonderful job out there as well. And now that we're able to provide this sort of care, which, you know, the footsteps have been put into play. You know, Dr. Mihalovich, who was the CEO out here, is now our global CEO. Just to sort of take this to the next level with this sort of acuity. Not that you ever want a pandemic, but it's sort of catalyzed what we're doing. So truly, you know, there's nothing better and more humbling that you have the ability to serve patients, you know, with the sickest and the most acuity in demand. So truly great. Next slide, please. So this is just an overview. So again, we, according to with our executive team, our chief medical officer, Dr. Madhu Sassadar, also from main campus, led a team of different physicians across the enterprise. And they started thinking about this, I think, end of January, February. They met daily. This task force, as you can see, there's a lot of information on there, but pretty much looks at everything from how many new patients we have in terms of locally on an international scale, what do we have in terms of ICU beds, non-ICU beds. We also converted three different non-ICU COVID floors because we had a large patient population there as well. And then also, you know, for PPEs and supplies. So this was done real time. And anybody who does critical care medicine, and why I probably enjoyed this so much, it's real-time medicine at its best. So as you can see, a very extensive array that our task force has done an amazing job with. Next slide, please. And then I would be remiss, so, which is even fantastic, and what symbolizes universal healthcare, and which I think makes Cleveland Clinic, I'm being a little biased here, but being 20 years with the organization, this is truly what it's all about. So we had about 29 caregivers who recently came here from main campus in Florida and the regional hospitals. We have 10 physicians, 29 nurses, and some other sort of support resources to help us out. And, you know, part of the reason that I'm even able to do this today is because a lot of them are my colleagues back home from our Anesthesia Institute. I also like to thank Dr. Troyanos for helping arrange this and getting there in our executive administration with Dr. Guzman and our OPSA to help make this happen. You know, once they were cleared within a couple of days, as I'm talking to you right now, we have full forces in the ICU, hospital medicine, emergency medicine, nursing. Truly amazing. I don't even have the right words to say, but it's inspiring. Next slide, please. And for those who know me, you know, back in Cleveland on Abu Dhabi, we're sports nuts. Those are my twins, Danielle and Zaidan. So we're big Cleveland fans. Even sitting in Abu Dhabi, I know sports is on a hold with our current pandemic, but hopefully things will change. But we still follow our Browns, our Cavs, and our Buckeyes, obviously at odd times. And to their mother's dismay, I keep them up late and wake them up early. But as I said, you know, we have to be all in. So next slide, please. So key takeaways, and I know we might go to some in between with with the questions and with the Dr. Zein, but I still say, and I sort of close all our webinars with the same message, and it's simple, but I think, you know, repetition is the key. You know, we've been blessed. We have a plan. We have great resources. We have great people. We have great executive leadership. We've risen up to meet the challenges. You know, another thing that I learned through this process too is, and I give credit to John Todt, my executive director of nursing, you know, don't let perfect be the enemy of good. You know, in these sort of situations, you have to be fluid, flexible, transparent, safe, and vigilant. You know, this is why we do what we do, right? Like, especially for us in critical care, this is the greatest calling that we're ever going to see in our lifetime. As Dr. Guzman, you know, pointed out to me, you know, this is a black swan. So this is something that they're going to talk about for generations to come, and that you have a part to actually help and make a difference. You know, there's nothing better. You know, as I said, this is probably the most fulfilling and humbling experience of my life. This is our call to action, you know, to steal the words of our global CEO, Dr. Mihalovich. You know, medicine is a calling. It's not just a job, and, you know, more so now than ever. So that's sort of my overview with
Dr. Nadeem, thank you. Thank you. Great presentation. I'm not going to get you yet off the hook easy. You presented a very positive, great picture, which is absolutely true. But help me with a couple things. So
Sure.
When we talk about critical care in the US, there is constant comparison between outcomes of patients in critical care in different states. For
Sure.
example, a patient who end up intubated in New York City have an 80% mortality, while in Cleveland, Ohio, probably 40% mortality. What was the outcome overall of the critical care management in your institution? That's question number one. And
Sure.
number two, I love to hear a word you listed briefly, medications you were participating in, whether it is plasma or whether it is, I don't know if you use hydroxychloroquine. I never practiced medicine in the UAE. I don't know what the roadblocks into treating patients with experimental medications, were there such things, and how did you overcome it?
Sure. In terms of, we're going through all our sort of mortality numbers right now, but I mean, I can initially, as we're going through everything, our mortality, God bless, is probably, I think, with people on a ventilator is about 5 to 7%. And I know that's going to sound striking, but there's different reasons for it. I think we've been lucky that we've actually had all the appropriate medicines, and we've been very proactive in our approach in terms of, we're probably one of the few centers in the UAE that actually does proning. We have ECMO services. And then in terms of using the interleukin-6 antibody receptor, telucimab, we've been very active, or as I say, proactive in utilizing that. So our numbers are still to come out, but initially they're very good. But again, I think a lot of that is being very proactive in nature. And then also, we're sort of being a transient population and in terms of expats as well. You also have some younger patients as well. So obviously, I think people's physiologic reserve also helped us in this situation. In terms of, again, we have different medical therapeutics that's constantly updated with our ICU team, our infectious disease team, our pathology teams. So, that's been a benefit as well. But, we try to stay away from any sort of experimental therapeutics per se.
Thank you, Dr. Nadeem. Dr. Abdely, Dr. Hayal, please proceed with your part of presentation.
Okay, yeah. Hello, everybody. Greetings from Riyadh. Just to give you first an info about my institution, King Faisal Specialist Hospital and Research Center is a healthcare organization with 3 hospitals, the largest in Riyadh with 1,200 beds. Then a smaller one in Jeddah, 500 beds. And a third one, which is about to operate in Medina, smaller, so about to start in a month or so. It's a tertiary care center with focus on cancer, organ transplant, cardiovascular disease, and genetics. And of course, we get complicated, complex cases. We get almost all cases through referrals. So we're not like an open hospital. We get cases from other hospitals because of the nature of care that is provided at King Faisal. With regard to COVID, when we first heard about the few cases that arise in China, we had our first task force meeting in late January with the memory of SARS, because the first case diagnosed here in the kingdom was actually diagnosed in our hospital 2003 with SARS. So we got people together, and also we have the experience with MERS. So we get people together, multidisciplinary, focusing on getting the test because the test was not available then, and also understand more about this novel virus then. By February, we got the test, and it's obvious we were at an advantage because for almost 2 months, we haven't had cases in the country. So that was an opportunity to prepare and get ready. And I think we capitalized on that, and we had to build a structure. If I may go back, actually. So we built a structure with high level led by the CEO with a command and control center commander. And then different platforms with the leaders. So one platform looking at transmission management, infection control mainly, then into bed capacity management, especially in the ICUs, as again, we learned from the experience of other countries and institutions of the main bottleneck, which is ICU capacity, manpower, PPEs, and ventilators. So that was the focus in our preparation plan. Manpower management and how we get enough, how we do cross-training, as mentioned by Dr. Rahman, getting different specialty to be trained in ICU care and also in COVID care. Then another platform for direct patient care in the floor as well in the ICU. Supplies was a big deal, of course, as you would imagine, with the global shortages in production of PPEs, ventilators. So a lot of work has been done around supplies. And I think our guys have done a good job getting the supplies early and also putting plans to conservation of supplies, trying to manage it and not overutilize it. We also focused on the staff engagement and education, communicating effectively with the staff through different venues, mainly utilizing the web and meetings. As you'd imagine, things moved to more of telecommunications for admin as well as patient care. Internal and external communication was key, and we focused on that through this platform. And again, we had also the help from the non-clinical support, from environmental, from project management. We converted a few floors to ICUs, and we increased our capacity by almost 30 to 40%. Although our capacity is not that bad, actually, we have a total of 176 ICU beds. However, many of them is dedicated for non-COVID, especially with the high number of oncology patients and transplant. So we tried to make a dedicated COVID hospital or a unit. And we managed to get a separate building, which was for medical patients. We evacuated and we made it dedicated for COVID patients. So there we had close to 200 floor beds and 27 ICU beds. Original 12, and we converted a floor with 15 to an ICU. And that will be good for our planned surge, which was divided into 4 stages, A, B, C, D. And currently we are at B, and surge B is confined to that building. And so far so good. We've been able to manage all our patients over there. We had a dedicated COVID team from intensivist as well as internist, and also from other services. So we had a share of different services in the care of COVID patients. So this CCC had daily meetings. So we meet every day at 10 o'clock, typically for an hour. We developed a live dashboard, so we monitor every process there. In terms of communication, the CEO had a live daily broadcast at midday to all employees through our web portal. And also medical, they have their meetings, nursing, they have their meetings. So also across all levels. It was felt to be critical that people are well informed, they know what's going on, and they get engaged. And of course, part of being part of the, the national plan for COVID control, many of us actually were part of national committees in the country to go with the regulations of the country. And typically during this, just if I finish this, typically during this meeting, we go over the capacity and surge plan because it's critical. We see how many cases we got. Are we having, different type sicker patients from where? Transmission, isolation, and contact list. Also, we had projection tools on the country, the city, and also our institutions, Riyadh and Jeddah. And of course, we look critically at the supplies status. And we discussed different issues, and we've been quite agile in, doing things differently whenever needed. And I'll show you, I don't know, Dr. Zein, if you have a question, I can take it.
I have a very, very brief question that this is obviously, it's actually similar to what we had here in Cleveland, but it's very complex structure and require a lot of attention. And I'm curious, did you have this structure in place from the 2012 MERS epidemic that you just put together for this, or what is of the many lessons you may have learned from 2012? What are the main things that helped you out to create this very complex management structure?
Right. Although it sounds complex, but it's running very smoothly because we have the leaders there, they're aligned, they're together. So things were moved quite well. Yes, at the MERS time, we had a committee which has the oversight to MERS. MERS, as you know, community transmission of MERS is limited, opposite to COVID. So the main concern was outbreaks within our institution. And thanks God, we have had no outbreak at all at our institution, although we cared of many MERS cases. And I think that speaks of the structure that has been built and the care that people were doing. So it's kind of part of their routine, kind of. I think the experience of MERS has helped here as well as other institutions in the country, definitely. And during the MERS outbreak, I was actually at the ministry and I was part of a command and control center. And also the structure was not very far from this structure.
Thank you.
Sure. So just to take you over some of the screenshots from the, from our dashboard. So this is the front page of our dashboard. We look at some of the numbers internationally and nationally. As you know, we reached 72,000 cumulative cases, and we watch every day the cases. And then you see here the surge plan and at what level we are. And it's a detailed surge plan, looking at space, manpower, supplies, processes, and we are at surge B. Our branch in Jeddah also at surge B. And then we basically see all the new cases, the cumulative cases, and the level of severity also from asymptomatic up to severe. And here we have a graph. Oh, this is the surge basically. So if you click on the surge, this is what will show you. This is surge B with a trigger to surge C. And these are the floors basically, and the occupancy like in red, occupied, and in green, non-occupied. This is again, the building that I've mentioned. It's east of the main campus, so it's distant from the main hospital. And here the ICUs basically that was created over there. Here the cases we monitor every day, and as you can see, in the recent days we had a little surge in number of cases that we had, averaging about 20 per day or so. So we look at that, we discuss all of these cases. What we do also, we look at our staff who are in isolation. As you know, because COVID is readily transmitted in the community and very effective there, it's likely to get, most of the cases from the community, and then with exposure risk among our staff. So we follow all of the staff, nursing, medical, allied, non-medical, and we check on them daily, and we find who's high risk, low risk, who's close to finish the isolation time and come back to work, because we were quite keen and conscious about the need for manpower. So this is, and also we looked at the consumption of PPEs, and this is just an example. Our N95, these are the types. And we've worked hard into reducing the consumption. So we made guide that only a result generating condition should require N95, otherwise should not use N95. And also we make a gatekeeper leadership in nursing to distribute it. So we manage actually to reduce consumption, and that helped us in our inventory for PPEs. We monitor, of course, the bed occupancy in the floors throughout the hospital here in Riyadh, also in Jeddah, and also the ICUs. We have our projection tools that we look at it for the country as a whole, so we can project, and it depends on 3 days average, also for Riyadh, and also the projection for the country, new cases as well as cumulative. And you can see here, I don't know if you see a gray and a blue, and that's a projection versus the actual, and the projection has been quite accurate. We measure the effective reproduction value to see where are we in terms of the epidemic within the country. One tool also which we thought was quite useful to us is a projection tool for consumption of PPEs. And here in Riyadh, here in Jeddah, and it depends on the effective reproduction value, and also the number of cases and projected number of cases coming in a median incubation period, which is 5 days. And then we can project it into 3 incubation periods, so 5 days, 5 days, 5 days. And then if we click, here it's a screenshot so you don't see it, but if I click on this, if the consumption is high, it will project the balance. And we get it from the oracle or from the supplies. And we can, accurately, near accurately say if we are going to run short or not ahead of time. So that was also a very important tool to us. One important thing is to get transparent, to get the staff all over, employees all over engaged. And here we had a dashboard that was created for the hospital staff, everybody, which has the numbers, international, national, and also for our 2 hospitals in Riyadh and Jeddah, and the admissions, new cases, and also some resources for all employees, like protecting themselves, managing stress and anxiety, which of course can happen in this, symptoms and testing and how they can reach that, and some questions. And as I mentioned, also we have the broadcast of the CEO also put here so people can refer to it. So this is in a nutshell what we have done, but of course I'm open to questions.
Thank you, Dr. Hail, very much. We have some questions. I'm gonna go through them from the panel, but I am gonna ask you to make a couple comments on migrant workers, both in Saudi and UAE. So there is, at least in the press, and I don't live neither Saudi or UAE, but in the press it seems like they describe higher rate of COVID-19 among migrant workers, maybe due to housing conditions, maybe other reasons beyond knowledge. Have there been receiving medical care? Are there efforts to educate them in their own native language? I don't know if language is an issue in that population or not. Any comment from either of the 2 countries, given the amount of press around this topic?
Right. Yeah, I think the data and it's actually, they have it in their daily report, at least here in Saudi. We had more of labor workers, migrant, and as you've mentioned, it's thought to be related to the crowded residence. And we've noticed it even at our hospital. We had few in our utility and maintenance, and many of them are labor worker, and they rent houses together, and they get together. So our only outbreak actually happened here with UMD, or utility and maintenance workers, because we believe because of the housing situation. So we at our institution level, we had a plan we executed a plan on education. We met with their management, and of course, care, we provide similar care to anybody. But education was key, and we start doing that for them. Language, yes, it is an issue, although in our institutions, less of an issue than other institutions in the country, where the language barrier is real. And I believe from what I read, it's throughout the Gulf.
Great.
Just to piggyback on that as well. So, you know, one of the great things here too with having the support of the nation here is, you know, we've been assured, you know, we take care of anybody, no matter who you are, from somebody working to a ground or to the, you know, CEO of a big corporation. And yes, we took care and are taking care of that patient population as well. You know, and honestly, that's what I said. It's quite humbling to take care of these patients. It's also part of the challenges too, because when you're in your most critical state, you're away from your loved ones. But this is where I'm going to give a huge credit to our team. The beauty, you know, part of CCAD is we have about 70 different nationalities who are here. So amongst someone speaks the language. So you may have somebody who's not even in the ICU, but we try our best on a daily basis to reach out to the loved ones. And again, our case management team, we have amazing case managers and social workers here, and they spend countless hours, you know, identifying who these patients' families are, because a lot of times it's not straightforward as all. But I said, giving this sort of patient care, no matter who you are, I mean, that's what we're all about. And we've been, God bless, we've been fortunate with our results so far.
Thank you both. So another quick comment for both of you about a topic that is very, at least has been front and center in our organization here in Cleveland, Ohio, which is caring for the caregivers. So there has been a report throughout the US, Europe, Middle East of shortage of PPEs, shortage of procedures and supplies for the caregivers who are taking care of the patients. Has this been an issue in either of your two organizations? How do you deal with caring for the caregivers? How do you make sure they are not going to carry the infection back home to their families and kids, and all these logistics that goes with making sure the frontline caregivers are going to be okay?
Right. We haven't had an issue because we've been able to manage the supplies. Education was critical, especially on infection prevention practices. And I think that really helped. In terms of not having it and getting it back home, even the scrubs they use, we made a policy that they leave it in the hospital and they should not go with a scrub. So whatever dress they have, they leave it here and it get to the laundry. So we want to make sure that they don't carry it back home. So far, so good. We haven't had any case that is relevant to transmission within the institution and carried out to a family.
Dr. Nadeem?
From our side as well, we've been very blessed to have enough PPE. That's not been an issue. Now, what you allude to with respect to, you know, mindfulness in the mental aspect, I mean, there's no doubt about it, right? As I said, the mentality is a sort of a war mentality. You know, when in society has everybody been focused on one thing, and it's an invisible enemy. So, you know, if you could look at everything that's coming out of Italy and New York, and I'm sure we're going to deal with it as well, is sort of the post-traumatic stress disorder. Ask anybody who's been in military operations. This is a fact, and we're going to have to learn how to deal with it. Again, trying to be proactive in our approach. We have a wellness team. We have wellness ambassadors. We have Dr. Lizette Cardona, who leads our outreach in that aspect. We put different programs together. We have coaching services. So, you know, we haven't dealt with it, or we haven't had the severity that they've had in, you know, some of the other countries. But again, I think part of that is being prepared, and you have to be, you know, literally, not to use that word, but you have to be mindful of these things that we're going to have to deal with in real time, because again, this is going to be an issue worldwide for time to come. But as I said, having the tools and the resources in play definitely make a difference. So we're dealing with that. Then, as I already alluded to, you know, we're blessed also, you know, with our investment, our Mubadala has also been able, with one of their sister companies, is able to provide us with all the appropriate PPE. So that's not been an issue. And again, as Dr. Hale mentioned as well, a salute to our services, our operations with laundry. I can't tell you, I mean, you see these are whites we wear here in Abu Dhabi at main campus, I believe still at Florida, though I've been gone from there for a little bit of time. But I mean, 24/7, everybody's working. I mean, that's the beauty of this, is how everybody has come together. Physicians, non-physicians, nurses, non-nurses, caregivers, which I think is the term that coins it best. And everybody's a caregiver, for somebody who's valeting your car to somebody who's mopping the floor. You know, as I said, united we stand, together we fall. So it's been great.
Thank you, Nadeem.
Right. Just to add from our side, we opened a 24/7 line for psychiatric psychology support. So whenever needed, you know, addressing this issue of stress, but we haven't had any problem with that so far.
No, actually, we had the same thing here. That is, we have a specialized group of psychiatrists, psychologists, 24/7 available for our employees. And actually, they have never been as busy as they have been during these previous 3 months. So certainly it had helped a lot. But I'm going to ask my last question before I turn to the audience questions. I know we have about 7 questions from the audience, and then they can also ask in person. But my last is a quick comment. So if, each one of you represent, serve, and work in one of probably the 2 most distinguished organizations beyond GCC, even in the Middle East, for medical organizations. So a lot of medical centers, hospitals, caregivers will look up to King Faisal, will look up to Cleveland Clinic, Abu Dhabi. Have you guys been willing, able to share your experiences, knowledge, your structures you put in place to fight for the COVID battle, as you like to call it, Dr. Nadeem, a battle? And have you been willing, have you reached out to say, hey, you guys in, I don't know, in Lebanon, in Jordan, have you guys in our neighborhoods, in Kuwait, other places, can we help? Is this something took place? It happened certainly through Europe during this epidemic.
Dr. Hill?
Yeah, I think, of course, we welcome this very much. At the national level, through committees, we have presented our work and how can we help. I must say also at national level, they have a robust plan and system running, and they are doing a beautiful job. Sharing to others, of course, we welcome that. There hasn't been a direct communication with other institutions, but personal communication with friends in institutions and sharing some of these, but not at official or management level.
From our side, this is very real time. So again, the beauty of being in our alumni network, or as I said, we had some of the largest fellowship programs back in main campus. You don't realize over 20 years, you have a lot of fellows who now are working all across the world. So as I said, I think we got hit with our pandemic a little bit later. So you utilized all your friends back in the US, in New Orleans, in Boston, in New York. And we've been constantly, this is why you have WhatsApp groups, communication. So the people who know me, my biggest challenge is I don't sleep because somewhere in the time zone, one of my former fellows is awake somewhere. So as I said, real-time knowledge that we all utilize to help. And hopefully future platforms like the one we're in today, we can further enhance other people's knowledge as well. But again, it's a tribute to the alumni network that we're part of.
Thank you both. So I'm gonna go through, I think now up to 9 questions from the audience. I will try to lump the topic. I won't state the exact question as written, but can either one of you make any comments on the testing? I know this may not be your area of expertise, but the question specifically talk about a lot of recent publicity, and even FDA put hold on one of the tests about inaccuracy, false negativity of one test, the value of antibody testing. So just general comments about testing and the shortcomings of testing.
We have the different PCR tests, of course, through different platforms, Roche, Abbott, others. And still they have this about 20% false negatives. So maybe repeating it will increase it a little bit, but this is a fact. For antibody test, reliability is an issue. So there is one for Roche, which was approved by the FDA, and a few others, which seems to be good. I see it as an epidemiologic tool to see how much we have those subclinical or asymptomatic, and see if the herd immunity is really happening in the community with mild cases or asymptomatic, totally asymptomatic cases. But in terms of management, and maybe at the workplace, again, you can ease up a little bit on the use of PPEs if you are short, if you think your staff, many of them, they have the antibodies. So other than that, I don't see it very useful.
Any comment, Nadeem, or we'll move to the next question?
No, honestly, Dr. Hill, full agreement in his comments. He sort of hit the nail on the head. So nothing else to offer from our side.
There was a specific question for you, Dr. Rahman, that is, did you refuse patients by age or comorbidities to be admitted to the ICU?
No, listen, the thing that sort of, we were sort of deemed in terms of like the secondary, tertiary, quaternary center of excellence. So, they had different strategic plans. So our goal, which is the Cleveland Clinic goal worldwide, is to take care of the people with the most complex. So if anybody sort of goes in that, sort of fits into that criteria, that's what we're here for. And obviously, if people's conditions change at times, and again, as I said, our transfer line is open 24/7. At the end of the day, we want to provide the highest care to each and everybody.
Great. Dr. Abdely, there is a question about when you talked about projections for both cases and supplies and so on. How did you come up with these projections? I'm assuming the question refers to where did the data come from?
Right. Right. So we took a typical patient in the floor and a typical patient in the ICU, how many times the nurse will come, and what will be her PPEs. And same in the floor, and then calculate it over time with also some calculation, which our health informatics, they put into the formula, and they come up with the calculation, along with the effective reproduction value, which will project how many ICU cases we'll get next week, how many floor cases we'll get next week.
And I think you showed the data that the actual cases ended up being very similar to the projection, so validating your projection numbers.
Right. They've done a good job on that, actually.
Yeah. There are 2 or 3 questions referred to the recovery plan. So now, okay, so maybe the surge came, maybe we survived the surge, and you put all these procedures in place. What's your recovery plan, and how are you going to manage the post-COVID patient, the non-COVID patient population now and moving forward?
Right. Actually, we were discussing it. Well, the past few days we've been discussing this, the recovery plan, and how we do it. And we had actually a group working on it, working on business continuity and then recovery. And it was, a plan was put. Again, typically if you get people together into a focused area, which is COVID care, that's easier than going back into this diffuse, going back to the new norm. And for that, we had a plan with all the stakeholders. I think it all hinged on patients and care of patient, and then how can you support it with the others. So we had a group currently working on that. And as, I don't know if you hear today, the government announced that they are lifting restrictions on curfews, lockdowns, and by a month time probably will go to near normal, keeping, of course, social distancing. So we're actually actively working on that, because in a month time, we have to be ready with the full recovery.
Nadeem, any comment on recovery or
Sure. So the interesting fact with us too is, so obviously, you know, we've had the increase in taking care of the high acuity COVID patients, but we're also seeing an increase in high acuity non-COVID patients. So as I said, back to the slides from the beginning, we have a good amount of beds that are COVID and non-COVID. And then, as I said, we're still, the next 2 weeks should be pretty critical and pivotal for us to see where we do in terms of getting more patients or not, or if we've sort of hit the plateau. But I think one of the things that we've also realized is, with, you know, less people going overseas for care, and we've started we're in the midst of starting a cancer center. So more high acuity cases as cancer and neurosurgical are now coming here as well. So we've sort of, again, this is a great part of our executive leadership to be ahead of the game and plan accordingly what ORs we're going to do, how many ORs we're going to implement, who we're going to bring back, and in terms of what service lines we're going to do. So again, you know, as Dr. Hale alluded to, this is what, you know, this is real-time, day-to-day things that we're making, you know, changes on the fly. As I alluded to in my slide set as well, this is being nimble, this is being fluid. What may be right today may not be right tomorrow. In essence, that's what critical care medicine is. So I think that's why the mindset is so important. But, you know, we're preparing for what happens post. But as I said, it's going to be a high acuity, high volume institution. And for those of us who've been with the Cleveland Clinic for a long time, it's music to our ears that we have the opportunity to provide this care for the great people of UAE.
Okay, now with the time running out, I'm gonna ask you for a one or two word response. So there are a couple questions about, did either of the two countries develop its own capabilities for testing, manufacturing the test locally or PPEs locally, yes or no?
Yes, we did here in our research center. As you know, the name is King Faisal Specialist Hospital and Research Center. So we have our research center, and they developed a reliable, with 100% concordance PCR test with constructed primers and the extraction and the assay. And actually, we do have it, and we are launching it, in fact, as a screening tool here at our institution.
Nadeem?
In terms of gear, so with you know, PPE and N95s, as I said, our investment, our Mubadala has led a production at Alain, which is, you know, a neighboring city nearby here. So they're leading the way and help assuring that we have all the appropriate equipment. And I said, you know, that's one of the benefits of being here, because even talking to my friends and colleagues back in the States and in Europe, you know, that's one of the challenges. And I know that obviously leads to a lot of mental turmoil as well. So as I said, we've been blessed and very fortunate to have some of these protective equipment being manufactured right here in United Arab Emirates.
All right. I don't know if you can answer the very last question in also very shortly. That is, there are a couple of people who are asking, is there a second wave of COVID-19 in your opinion?
Dr. Hale?
It's likely. It's quite likely. I mean, history tells us yes, there'll be a second wave with opening. we know that data indicate that some of the serological data indicate from Sweden, for example, about 7% or so in Stockholm County. So I think still a lot of non-immune out there, and it's likely to, yes, it's likely to happen.
Nadeem?
From my side, it'd be sort of, super wishful thinking. You hope there wouldn't, but the reality of the situation is most likely, as Dr. Hale alluded to, that there will be a second surge at some time. Now, when that exactly is going to happen, is it going to happen in July, August? As you said, it's the constant vigilance and monitoring that will take into place. And I say life experience is your best teacher. We've gone through so much in a short amount of time. As you said, talking to wonderful people like yourself too, and talking to our colleagues all across the US, if it probably will happen, but we're going to be prepared. We've been well prepared, but you'll be even more prepared now. So, as I said, the enemy can sneak attack again, but we'll be ready.
Okay, with that moment, first I would like to apologize for the few of you I could not get to your questions. You were writing questions faster than I could get the answers for. So I think we skipped a couple. If you like us, please email Joe and he will forward it to the panelists. With that, I'm really sincerely, genuinely grateful for both Dr. Hael Al-Abdely and Dr. Nadeem Rahman for taking the time in this busy COVID time to be with us and to educate all of us and to help us understand where we are, what direction are we going, and how to manage along the way. Thank you very much. Thank you, Joe and team, for a great webinar. I'm honored to have been involved.
Thank you, Dr. Zein, and thank you all for joining us today. I want to thank Dr. Nadeem Rahman, Dr. Hael Abdely, and Dr. Zein for moderating. Also, we welcome you to take our follow-up survey that'll be sent out shortly as we want to continue to improve. And we will plan on having our next episode here in the next 2 to 3 weeks. So look for notification on that. Thank you all and have a wonderful evening.
Thank you.
Thank you.
God bless.